Good morning, everyone. My name is Ty Steele, and I'm the one of the journalists at KCRA3 in Sacramento. I'm honored to be your MC for today. And we are here today to talk about behavioral health and why it's so important, not just here in California, but across the country. We're also here to demonstrate yet again that our state is a leader and a trailblazer in the effort to address behavioral health challenges. Today, you will be hearing from people who work at the forefront of California's behavioral healthcare system, who have come together to create a landmark blueprint for behavioral health in California. This is years in the making. It's based on decades of experience and including broad and diverse lived experiences. And the timing of this blueprint could not be more perfect. California's recovery from COVID-19 depends not only on getting shots in arms, but also helping to heal hearts and minds. Both are truly critical. Behavioral Health Action is an extensive coalition of more than 50 statewide organizations with behavioral health expertise in California. And the coalition's blueprint for behavioral health outlines a new vision for California's behavioral health care system at a time when more and more Californians are experiencing behavioral health challenges than ever before, in large part due to the challenges faced by the COVID-19 pandemic. Without further ado, I would like to introduce our first speaker for the day. Her name is Carmela Coyle. She is the Behavioral Health Action Co-Chair and President and CEO of the California Hospital Association. Carmela, thanks so much for being with us today.
Thank you so very much, and good morning, everyone. We want to thank you for joining us for this important conversation. I am Carmela Coyle, and I serve as the co-chair of the Behavioral Health Action Coalition. We are a group of over 50 organizations with expertise in behavioral health who have come together to try to provide solutions for the state of California. And I also serve as the president and CEO of the California Hospital Association. So behavioral health, mental health, and substance use disorder needs have long been a challenge in the state of California. But now, with this COVID pandemic, we are facing a tsunami of behavioral health need like we have never experienced before. Before the pandemic, we had a system that treated physical health and behavioral health needs very differently. We had insurance that covered physical health differently than the coverage that was often provided for mental health or substance use disorder needs. Far too few services that were available in the community. And as a result, too many Californians for whom the only source of care was a hospital emergency department, usually not the best place to provide the kind of care and resource that's needed. Now, with the COVID pandemic, those challenges have multiplied. So we've got all of the same problems we had before the pandemic and more. And the data are arresting. More than half of people lost their income or employment during the pandemic. Those who did report negative mental health impacts. Black and Hispanic adults are more likely to experience job loss and pay cuts, and that means they are at even greater risk of behavioral health needs. Lower income individuals, people who earn less than $40,000 a year, report higher rates of major negative mental health, behavioral health needs, and people over the age of 65 are reporting increased anxiety. Here's the one that's really challenging, and that relates to our children. We've got parents with kids in K through 12 schools who are reporting concerns for their children's social and mental wellness. And we know that adolescent suicide was on the rise before the COVID pandemic, and those numbers have not abated. So one of the big lessons we learned in the COVID pandemic here in the state of California is we had to address it differently. Normally, public health challenges would have been handled one county at a time, 58 different ways in the state of California. But the pandemic required a statewide solution and statewide collaboration and action. And the very same is true for behavioral health challenges here in California. Unfortunately, in our state, behavioral health is largely left to counties. And that means the care that you get and the resources that are available are different depending on where you live or where you happen to be at the moment that you need help. We cannot do this 58 different ways. We are in need of a statewide solution, and that is part of the reason that brought these 50 organizations together to create the Behavioral Health Action Coalition. Long after everyone is vaccinated and the clinical crisis is over, and we can't wait until that moment, we will still be facing a behavioral health crisis. We cannot go back to the old system of care. That is a system that was inconsistent and inequitable and reactive, really largely responding after someone is in need of care, and a system that largely landed people in the wrong place, usually a hospital or a jail or a prison. We have got to do better in the state of California. Our Behavioral Health Action Coalition is offering a new and better path forward. We gathered the best experts, and we are releasing today the Blueprint for Behavioral Health. It is a guide for policymakers, and a really important guide for policymakers of all of the opportunities we have at this moment to create change in the behavioral health system. We want to create the key priorities, the places where those changes are needed most. And at its core, this Behavioral Health Action Blueprint does one thing, and one thing only, and that is to encourage policymakers to flip the triangle. Now, what do we mean by flipping the triangle? Think for a minute about the shape of a triangle, where the space at the bottom is far greater than the space at the top. What we have done, not only here in California, but nationally, is we have put most of our investments, that bottom space, in acute care needs, in trying to respond to behavioral health challenges. And that space at the top, the pinnacle, has been our investments in prevention and early intervention. Far too little invested in prevention and early intervention, more perhaps than should be in those acute care reactive needs. We want to take that triangle, and in this blueprint, what we do is we flip it upside down. We need to invest heavily in prevention and early intervention so that we can spend far less on that very costly acute care needs, often after the fact, after all of the steps in between that can help to keep people stable and healthy and moving forward. So never has there been a more important time for Californians to come together and not just to plan, not just to talk, but to act. Now is the time. We cannot wait any longer to create a better behavioral health system in the state of California, and we need to do that now and play this long into the future, continue to make those investments. If we don't grab this moment, we will miss the opportunity to really benefit Californians of all ages and all types. I am proud to have been a part, and the California Hospital Association is proud to have been a part of the Behavioral Health Action Coalition. And I can say that California's hospitals are committed to the dramatic change that is needed and outlined in this blueprint. So now it is my pleasure to introduce to all of you our Behavioral Health Action Coalition co-chair, Jessica Cruz. Jessica is a good colleague, a good friend, and has been a great leader throughout this multi-year work. Jessica, as I mentioned, is co-chair of the coalition, but she also serves as the CEO of NAMI California. Jessica.
Thank you so much, Carmela, and thank you everyone for being here with us on this monumental day for behavioral health in California. I am Jessica Cruz. I am the CEO of the National Alliance on Mental Illness California, or NAMI, and I'm the proud co-chair of the Behavioral Health Action Coalition alongside my friend Carmela and the California Hospital Association. NAMI represents families and individuals across California and across the nation. We are the leading organization representing the individuals and families impacted every day by serious mental illness. As Carmela had mentioned, this pandemic will not be over once everybody is vaccinated. That second wave of the behavioral health crisis is going to wash us over. if we are not prepared. The current system, we have to recognize, is inadequate, and our response is not sufficient. For example, if somebody's having a heart attack on the side of the road, a physical crisis, we call 911, we respond in compassion, we hold their hands as they go into the ambulance headed to the hospital where their families await them. The doctor talks about the treatment plan alongside the family and how that individual can live a healthy life as long as they follow the treatment plan. Somebody who is experiencing a behavioral health crisis on the street corner, we run from them. We call 911, and instead of a compassionate response, we receive guns, we receive arrests. If they don't go to jail or prison, they are sent to an emergency room where they wait for 72 hours and sometimes not getting the sufficient care that they need. Their families are definitely locked out of any kind of conversation. And if they go to a psychiatric hospital, they're behind closed doors. The coordination of care between a psychiatric hospital and their primary care is limited, if not non-existent. The two responses between a physical crisis and a behavioral health crisis have to change. And that is exactly what our Behavioral Health Action Coalition did. The 50 organizations came together and said, we have to make a difference. This is a resource for leaders. It is a guide for policymakers on how we can actually make that change. California must set and monitor goals to improve by at least 10% per year 6 indicators. Those indicators are to reduce the delay of onset of symptoms to treatment. Right now, the current gap between the first onset of a symptom and somebody receiving treatment is 8 to 10 years. So much can happen between that time. We must reduce by 10% every year that treatment gap. We must reduce the disparities in behavioral health utilization among racial, ethnic, sexual orientation, and gender identity populations. We must reduce the proportion of behavioral health individuals in jails and prisons. We must reduce the rate of rehospitalization once somebody has been hospitalized in a psychiatric hospital. We have to increase the screenings for behavioral health treatment amongst children and youth, and increase the satisfaction among those receiving the services, those individuals and family members. We know we can do this. We know progress can be achieved as long as we adopt goals that are both enforced for their effectiveness and that are equitable. I am so proud of this behavioral health blueprint. I am proud of this coalition. We at NAMI California are proud of the work that we have done throughout the years and our partnerships. It is my pleasure to introduce somebody who has been a role model, has done work for the community for 45 years, is the executive director of the Progress Foundation and a dear friend, Steve Fields.
Thank you, Jessica. Thank you, Carmela, for that important explanation of the origins and challenges that we face that have created this unprecedented document that represents a coalition of broad-based organizations and advocates and consumers and family members across the state. Jessica's right. I mean, I began my work in Community Mental Health. Progress Foundation, by the way, is a nonprofit provider based in San Francisco, Napa, Sonoma, and we're proud to say now in Napa and in Marin County. I began this work right at the dawn of the deinstitutionalization movement as a public policy nationally. And the optimism behind that movement was to move from state hospitals and incarceration in large state institutions to a brand new vision that was shared by so many people of community mental health. Let me say simply that having been in the middle of those discussions and those attempts to implement services in the community, there was a fundamental problem with the way that we addressed the deinstitutionalization for people who had severe mental illness in our communities. And that was that we started at the top. We started with hospitals, we started with emergency rooms, and we started with a medical response to the mental health conditions people were presenting. We should have inverted this triangle that Carmela described right from the beginning. Give you just one stark example of the consequence of that method of addressing mental health needs in the community is it was 20 to 25 years after the closure of state hospitals began that the issue of housing, the critical role of housing in the lives of people who are struggling to recover from mental illness and substance use was not even a part of the important services for mental health until the mid-1990s. And that's just one example of how we got off on the wrong foot. And we've been struggling for 3 decades in a very aggressive way in California to reverse that triangle. But we haven't had what's been important, which is the leadership required on a statewide level and what we're calling a blueprint for effecting that change, where we start paying attention to why there are 26-year-old young people who have been in a system for 10, 12, 13 years without really seeing appreciable improvement in their lives or the lives of their families who are struggling so hard to help them. So we come to this moment with this blueprint for change from my perspective of working in the system for all this time. Progress Foundation has worked as a primary focus on providing alternatives to institutional consequences for people with mental illness, hospitalization, emergency rooms, long-term skilled nursing settings, and increasingly the real tragedy of a system that has not yet understood how to design an effective response, which is the overwhelming number of inappropriate use of jails and prisons for people who need treatment in the community. So what I see from a day-to-day problem of implementing mental health services in the state of California, Carmela referred to it in one way, which was very stark. Let me put it another way. If you're having an acute mental health crisis and you get on a bus at the Mexico-San Diego border, depending on where you get off that bus as you head north through the state of California, you're likely to get entirely different options and choices and treatment systems of care from one county to the next. It's as if mental illness and substance use change when your geography changes. But we know differently. We know that the realities of people struggling with severe mental illness and often concomitant substance use treatment needs are familiar. And the ways to intervene, we've learned a whole lot about how to do more effective work. But our jurisdictional structure, as Carmela referred to, the 58 different counties and jurisdictions, makes it hard to have a statewide policy on what are the effective systems of care that we can bring to bear in order to flip this triangle, where we're reinvesting in early intervention and we're reinvesting in prevention interventions that emphasize recovery, not just stabilization. The paradoxes of our system right now are that we know more and more every day about what's effective and what works for people who need mental health treatment. We know if we intervene early in communities that are victims of inequity in healthcare for generations. We know that if we can intervene early and understand how much trauma and early childhood experiences lead to an eventual involvement in mental health system. But we have to have the leadership and the political structure to have a coherent and cohesive behavioral health system. And what the behavioral health actions document, the answering the call to action, does is, for the first time, and it seems surprising to have to say this, but for the first time, we are laying out an example of systemic best practices. There's so much innovation and so many effective programs in our state. We have the leadership of the Prop 63 initiative. We also have finally the understanding that recovery is a goal of intervention and treatment, not just treatment and stabilization. We have these programs throughout the state. We have them in different communities, but too often one county or one jurisdiction, one neighborhood doesn't know what's possible because they have not seen what other communities have done. What this document does is it brings a statewide experience and perspective to laying out a template that any county can use to guide their development of a 21st century behavioral health system, to guide their development of looking at where the inequities occur in our treatment system and how to intervene early in communities, how to intervene with a methodology that does not set a course of constant involvement in the treatment system. And finally, what are the elements of a treatment system that lead toward recovery, a continuum of care, if you will, that's interrelated, that has as its goal, whenever possible, to offer the opportunity for people in the behavioral health system to lead toward recovery and full and what they would consider on their own terms, happy and productive lives. We can do this. We have the elements. Now the challenge for California is to get the state leadership and to get the professional and health and mental health community together to agree on a direction, to agree on a priority for early intervention and prevention, to agree on an array of services tailored to each community, but actually provide this opportunity for recovery, growth, and change for the people in our system. This is an exciting time right now. I've in some ways started on this discussion in the 1980s. There are a lot of challenges for implementing it at the community-based level. But I know, just in my small way, as many other agencies know, what is possible when a client comes into a program, they seemingly have no avenue to get their lives back, to get their opportunity to work back. And every day at Progress Foundation, as with a lot of other community-based agencies that are struggling every day, we see lives change. We see lives, we see growth. We see despair turn to hope. We see people who actually see an avenue out of a constant cycling into emergency rooms, hospitals, and jails. This document, which is just a representation of the commitment of groups all over the state, gives us that directional opportunity. And now it's up to us to seize it and to make it work this time and move forward. And I'm really excited to be a part of the partners in the coalition. And I'm actually excited to look at what comes next, which is the hard work with the state leadership and the leadership of these organizations to make sure this isn't just another document that gets set on a shelf, but it actually becomes the guiding principles by which we finally create a cohesive, coherent, and agreed upon direction for behavioral health in California, and not just for public programs, but for the private sector as well, and their responsibility to treat behavioral health in the same way they treat physical health. So I'm ready to roll up my sleeves, and I know Jessica and Carmela are, and our partners who helped put this document together to make this happen this time. We can't lose this opportunity for change. Thank you.
I'm sorry. Okay, well, I wanted to say thank you to Carmela Coyle, Jessica Cruz, and Steve Fields. And my first question to kick off our questions for the media would be to Steve. And that question would be, how will housing play into the overall conversation about the recovery of those with mental illness? Because this is something we talk about in the news every day. The homeless issue that's going on right now, so many folks are out there experiencing that, and communities are trying to figure out, how are we going to deal with this?
Yes, it's a great question, Ty, and it probably is the way in which this challenge is most often experienced by the public in general. Let me
Right.
say this about the relationship between severe mental illness and substance use and homelessness. And sometimes I think it's important to distinction. Homelessness is a consequence of being mentally ill in our culture and our society. It's a consequence of substance use. It's not inherent. It's because our people who are in the mental health system often have so little economic power, so little way to rise above stigmatization that even available housing is often inaccessible. So what we do know is this, that whether it's a treatment program that provides housing or it's a long-term, stable, dignified housing opportunity for people, unless you have a place to live, unless you have some stability in your life, it is almost impossible to make gains in addressing your mental illness or your substance use.
Right.
And so it's fundamental to recovery because it's the basis for a good intervention.
So for this,
If I can add to that, Ty, real quickly,
Mhm.
I think it's also important to distinguish the fact that housing and homelessness for people who are living with serious mental illness are very different too, right? People who are living with serious mental illness are oftentimes the poster children for this is what homelessness is.
Mhm.
And we know that there has to be a significant investment in housing for the serious mental illness population. So that has to have housing that has services and supports around them to keep them housed. And, Steve runs some great programs in his area that help with that. So there has to be that distinction between, the money that is going into housing and that of those people who are living within the population of the homeless that are living with a serious mental illness. And we don't talk about that as often as we should because it's a significant investment that also needs to be tied to the housing population.
Carmela, how would you add to this conversation?
Well, first of all, my thanks to Steve and to Jessica. I think from the perspective that I'm used to looking through, and that is the window of the hospital emergency department and connecting directly to this conversation on housing and homelessness. In the hospital emergency department, we're an enormous catcher's mitt, right? We are catching all of society's challenges and issues and problems. And what we're trying to do, I think, in this blueprint is to create a framework for how to think differently about a system of care and support for people with behavioral health needs. And while, our hospital emergency departments do a great job in caring for people at their most serious points in care needs, it's not ideal. What we really need is we need to be caring for people in the community. We've got to have a place to transition people for their behavioral health needs to what is a long-term and ongoing treatment plan. They need to have housing that is safe and clean and a feeling of not only security, but a feeling of calm to be able to really stay well and be well when they can. The hospital emergency department will always be there for acute care needs. I think our goal in flipping the triangle is to minimize that need and to keep people as well as can possibly be. We've just got to invest and think very differently to be able to do that.
Carmela, thank you so much for that. I've got another question for you. When it comes to flipping the triangle, prevention first, what exactly does that look like to you?
Well, I'll start, and I know Jessica and Steve will want to talk more. Unfortunately, as Jessica described at the top of this, many of us, and I would be surprised if all of us, don't have a family member, a friend, someone who has experienced a behavioral health challenge or crisis. But there are few places to reach out for help. And often 911 is the first thing that we do. And we end up in the wrong door, in the wrong system, as Jessica described, often on a policing path rather than a care delivery path. But that's the first step in this process and in this change that we're calling for. Where do you call? Who do you call? Where can you turn for help? We've got lots of acute care solutions, but who do you go to? Where do you start when a family member, a child is experiencing some things, showing some symptoms, showing just some behavioral changes that don't feel right? We don't very often have those first steps, those early steps. Who can you call? And worse, very often it's a 2 to 3 week wait to see if your insurance coverage will pay for it, if you've got insurance coverage at all. So our options are all turned upside down. And that is what we'd like to see: more community-based solutions, places where we can get early intervention and prevention. Who's at the other end of that telephone, who you can call and get some guidance? But very often we've got a system that has been built to wait until things are very serious and sometimes too late.
Carmela, thank you. And now we would like to take questions from members of the media that are joining us. If you'd like to ask a question, please use the reaction tool to virtually raise your hand to be placed in order for questions. And just to get that conversation going before we get to our media partners, Jessica, physical crisis and physical, we're talking about physical crisis and then physical encounters as well. When we're talking about that, we're talking about the triangle that we've been mentioning. And when somebody's having an actual issue, it's at the acute portion of that triangle. They're at the top of that triangle. How do we address that from a fundamental level?
Yeah, so we know research shows that people who receive early intervention, 80% of those individuals who receive that early care are able to manage their behavioral health over their years. So we know that early intervention works. But as Carmela had mentioned, we have a system that has been built to just wait until people are a danger to themselves, others, or gravely disabled. So somebody has to get to the worst point in their life to receive any kind of wraparound care. But we know that 99% of the time, those individuals are with their families or in the community. So why not have a community that is educated, that is able to access community supports and care early? Why not have a system where going to your primary care physician or your pediatrician is equally as reliable and available as having to go to seek a psychiatrist or a psychologist appointment? Why is it that we have to pay so much out of pocket for our children to go and get counseling because we as parents maybe see some early signs and symptoms? That's what we're trying to say here, is we have to start really investing in seeking that care early. It's not to say that individuals may not be at the more acute end of the spectrum. So we still need to have services available, and that is at the bottom of the triangle, because we have to recognize through the age spectrum and actually through the spectrum of severity of behavioral health issues, there needs to be supports. But if we can flip it so that people can get the access early, again, research is already showing that 80% of the time people who receive that service early are able to manage their behavioral health.
So Jessica, give us some more insight into how that early intervention would look as opposed to what it is right now when it's that 911 call. I've got a family member that is freaking out. What does it look like to get before that so we don't have to come to that 911 call?
It would hope that you didn't get to that crisis, right? It would be able to walk into your doctor's office for a routine checkup, and a part of the conversation is, here's what's going on with me. And that doctor, that primary care physician, feeling confident and comfortable enough in the knowledge and education that they have of the community resources that are available to them. It's a no wrong door approach, right? It is being able to have the conversation with your family and friend. It's being able to have your child available to talk to a crisis counselor or a counselor at school. It doesn't have to be crisis. A counselor at school, what's happening at home. There are a lot of children who are living within households where their parents or their loved ones are dealing with behavioral health challenges. And that has a severe impact on the children themselves. So where do they go, right? It is having a no wrong door approach, but we have to make sure that we're educating the systems appropriately, and funding the systems appropriately, utilizing peers and family members who have that lived experience and partnering with them, and community-based organizations like the ones that Steve runs.
And Ty, if I just really quickly could add to that, Jessica's exactly right. And but the other most important thing also in this, and it's embedded in the remarks that we made, there's so much consequence for people who are in communities of color, communities where there aren't services, communities where the services have treatment personnel who don't look like them, who don't speak their language. We have a lot of work to do in our public systems of care of making voluntary participation in a treatment intervention something someone chooses early in their crisis. We see every day in my agency people who waited, as Jessica says, for a crisis to keep getting stronger because the stigmatization of showing up at a mental health center, the fact that they've been in before and found that their own experience as people of color was not valued or noticed in the treatment environment they were in. We need more early intervention, low threshold programs in the communities where we're seeing the most people who are experiencing acute psychiatric symptoms and have the least resources to go to early to get the treatment they need. And that's a part of this blueprint. There are programs described in there that specifically put a priority on having relevant services to clients. There's, a big argument around involuntary and voluntary care. And let me just tell you, I have learned in my work over 50 years, if you offer something somebody wants, because they're hurting, they're looking for help, they will engage in it if they see that service understands, has a staff that looks like them, who comes from their experience. They will participate voluntarily much more than people understand. But too many of our systems are not responding to those kinds of challenges in our communities.
No, Steve, that makes a lot of sense. And I'd like to throw out another shout out to our media partners, anybody that may be listening to this conversation. If anybody has questions for our speakers, we'd love to hear from you. For me, Steve, I'd love to ask you a question. So when it comes to early intervention, which is the key here, I think that everybody can agree on early intervention is the key to solving these issues. What does that look like? Describe to me what happens when a family member, a friend sees somebody that is having a problem, and maybe this is an ongoing problem. Where's the first place to call? I mean, 911, of course, is the last call that we should make, but what's the first call that we should make?
Well, let me say you one of the, there's institutionally, structurally, and it's again embedded in some of the information in the call to action document, is we need a much more robust school-based intervention, where in a normalized environment where a child is starting to show some difficulties, where the intervention is in that natural environment, and it's between the education professionals, the staff, but also the families to intervene early. So it's not a matter of taking someone out of their environment and treating them, but helping them in their environment. But it also, let me just say, there's a national movement going on now, which is to introduce a new telephone number besides 911. And it's not a small issue. There's a 988 number that has been nationally promoted by suicide prevention lines, but it extends well beyond that issue. And the California legislature currently has a bill that would implement the 988 number for behavioral health crises, so that the call is not channeled through the very same mechanism for response that in dangerous situations that end up with a police response. So that would go a long way toward, I think, being able to separate the problem of somebody who's in a crisis and upset, and say somebody calls 911 and the first thing you get is a police response. 988 would provide a different structure for an early intervention of a peer, a social worker, an EMT to come out and do an assessment that's not based on dangerousness, but based on helping the person deal with that immediate crisis. And the other thing that's critical, and this is why the breadth of the call to action document is important for counties to understand, is that you can intervene in a crisis, but if you don't have a place to send someone for ongoing structured support and treatment, then it doesn't do any good. Have this built out system of care that if you go out and you intervene early and you have a chance to head off a crisis before it reaches proportions of needing to be hospitalized, if you don't have somewhere to send that person where they will feel safe, they will feel responded to, a 24-hour treatment program, for instance, in the community instead of in the hospital, then you're just doing an early intervention. Someone may go in the hospital for 8 days and they're right back into the problem that created the tension the first time around. So the critical part of this is, the other part of prevention, which is primary, secondary, and tertiary prevention. We're trying to also describe a treatment system that has secondary and tertiary prevention models for people who've been caught up in that cycle of hospitalization, back to a lonely hotel room in downtown with no treatment support. You end up, and then you're back in the hospital, and that constant recycling. The community needs to have a tertiary and secondary prevention model that clients will voluntarily participate in because they see the value in it.
No, that makes sense, Steve. Okay, so we have a question from the OC Register. Can folks please speak to the problems we've seen in the private sector where patient brokering and fraud are still happening, where anyone can open a residential rehab, and where lawmakers are pushing for better state oversight? Very specific question. Anyone can answer this if they feel that they want to answer that.
I think all of us see a piece of that. I don't have a whole lot of direct experience but let me just say this about that dilemma. It grows out of the lack of common policies and practices that Carmela referred to in the private sector and the hospital insurance sector compared to the public sector. And I think that one of the problems with that for behavioral health is that those kinds of programs thrive on narrow benefit programs within health insurance plans or within various health entities that will pay for various kinds of recovery programs. But they're in a different world. I mean, the outcome measurements of that is not based on the kind of outcomes that we're trying to see in the public system of care. One of the ironies, Ty, that I've noticed over my career, it's generally true, and this sounds paradoxical, but if you're in the public behavioral health system in some states, in some place, and I will say in many parts of California, and you come into the public system because of your status doesn't allow, you don't have insurance, you're poor, you're in Medicaid, you actually have a better chance of getting a recovery-based, non-stigmatizing intervention than if you go into the for-profit or the large hospital systems. That's one of the outcomes of this discrepancy between what's required of insurance plans to offer.
How do we bridge that? How do we bridge that gap, Steve?
Well, we're trying it legislatively. We're trying it with the parity pressure being put on plans. We're trying to address the question of people whose insurance runs out, so they refer them into the public system of care. My agency runs a continuum of care, just as one small example. Well, we do acute diversion from the emergency room. We do transitional residential treatment up to 1 year in the community for individuals in small 10, 12 bed residences in the neighborhood. And then we do supported living, as Jessica referred to, in apartments all over the city of San Francisco. So we run a continuum of care that's designed to move people toward recovery when they're ready to move at the point they're most ready to do. That model of that range of residential is not funded by virtually any private insurance plan in the country. You cannot get crisis services from almost every insurance plan in California. And you certainly can't get 6 to 9 months of treatment, except for substance use disorder alone. But for severe mental illness, it's not part of the benefits packages. So the pressure that has to happen publicly, and a lot of people are working on this, is to bring the private plans and the private market into understanding their responsibility to contribute to people getting better. Because when they don't get better and they get worse, and pretty soon they have no connection to family, they have no insurance coverage, what system is serving them? It's the public system of care. So we're one system of care, and I don't know how long it's going to take, but we have to integrate the responsibilities and the expectations. Whatever it is that the private markets utilize government support for, they need to see their obligation to come in and provide the same services that the public system does.
And I wonder if I may add to that, Ty, and it's part of the function of the blueprint. We've talked about a system that's inconsistent and inequitable and reactive. Part of what we're trying to lay out in the blueprint is a set of goals and objectives that we can all get behind. And that is to create a system that is more consistent, more equitable, proactive, and out in front. And I think the more that we are united around a set of goals and objectives, the more that we are setting measurable activities, right? Important metrics that Jessica shared, and working on those together, it will create the kind of alignment and the kind of transparency, quite frankly, that I think we need in building a new and different behavioral health system.
And in line with that, when communities are frustrated because they see their homeless population growing, they see the mental health crisis playing into that, what can we, this question is for anyone in our column right now to talk about, what can we tell our lawmakers as far as the best advice for policies moving forward? We talk about housing, building tiny homes, allowing tent villages to exist. Is that the best strategy, or is there another strategy when it comes to housing folks who are out there and battling mental illness and drug addiction?
Well, I'll jump in first, and I know Jessica and Steve will want to add on. I think what we're suggesting to policymakers, first and foremost, we need a plan. And that's what we've put together, that we need to all be pulling on the same rope in the same direction, because this is an enormous challenge for us to deal with, that we need to focus on best practices. They're out there and we know what they are. This is not an overnight fix. This is going to be years in the making. But if we can stay on course with a plan to take advantage of the best practices, and again, to flip that triangle, this is all about now's the time to invest in prevention and early intervention. If we can stay on that course, there will be hundreds of ideas for how to make the behavioral health system better in the state of California. We're just trying to provide that guidance to say, these are the kinds of measurable outcomes we're looking for. And first and foremost, prevention and early intervention, invest there first.
No, that makes sense. Carmela Coyle, thank you so much. And thank you to all of our participants for comments and all the work that has been gone into creating the BHA Blueprint. And now we would like to, we've of course taken questions from the media, but we would like to wrap things up today and just thank everyone that's been involved because of course, this is an ongoing challenge. It's an ongoing question and answer scenario that we have not reached the end to, but we definitely know that this is a conversation that needs to be had. And it'd be hard pressed to find one individual in California or across the nation that has not been affected directly or indirectly by behavioral health challenges in our state. So thank you so much to everyone out there who's been joining us. Thank you, Jessica Cruz, Carmela Coyle, and Steve Fields.
Thank you.
Thank you.